I'm also a clinical nurse specialist by trade. So I'm here to talk to you guys about sepsis today. Please feel free to use the chat feature. If you all can't hear me very well, I'll speak up. I'm trying to think of all my housekeeping things. My cell number is listed here on the presentation slide. Please feel free to take that down too. I'm happy after the presentation, if you guys digest the information and you've got some other questions, I'd love to be able to help you all work through that if necessary. I have no relevant conflicts of interest to disclose. And this is for CME credit. I do have an informal disclaimer, however. So you can see here a picture of adults. I am an adult health clinical nurse specialist by trade and by education and training. So we do know that the OB population can also become septic, but we're not going to focus on our OB population today. And I also have a couple of pediatric patients, if you will, in my care, pediatrics, but that is certainly not my specialty either. So we're not going to focus on the pediatric population. Again, we will focus on the adults. So we're going to have a talk about sepsis in the adult population. So our objectives for today, I'm sure probably most of this, some of this is going to be a review for you, but as with anything that you hear either the second or third or even the 100th time, I'm hoping that you capture at least one new nugget of information that you can take back to the bedside with you. So we're going to talk about the diagnosis complexity related to sepsis, a little bit about the historical perspective, and then we're going to talk about post-sepsis syndrome and some of the goals of care related to that post-sepsis syndrome piece, which is fairly new in the literature, though not a new concept for our patients. So starting with the significance of sepsis, when I think of why this is important, these are sort of the hot spots of interest that come to my mind. So you can see on this slide that a lot of people become septic. It kills, it's the leading cause of death in the United States in our hospitals. It's the most expensive condition in US hospitals. And then the part that I think is really interesting is they're about readmissions, having the strongest association with hospital readmission. We're going to talk about that a little bit later. And then of course, that secondary outcome, which I've mentioned related to that post-sepsis syndrome, up to 50%, half of the patients who have had sepsis leave our hospitals with some element of sequelae related to their sepsis experience, also called post-sepsis syndrome. So as far as the evolution of sepsis, I use that term in quote up there because generally speaking, it hasn't always been known as sepsis, but as far back as 100 BC, it's been cited as small creatures invisible to the eye that fill the atmosphere and if breathed in, cause dangerous disease. So it's been around for a very, very, very long time. We're not going to start all the way back there. We're going to start in 1990s when the early goal-directed therapy collaborative group put forth the paradigm shift or the concept that sepsis care is not an ICU disease, but really we need to be thinking of it as presentation in the emergency department. So in the 1990s is when we really started to flourish and see a lot of that, that research coming out. In 2001, the seminal research by Dr. Rivers with the early goal-directed therapy was released, and of course, you all are very familiar, stated giving the fluid boluses and sooner rather than later, emphasis on we need to treat these patients as soon as possible. A year later, the European Society of Intensive Care Medicine, in collaboration with Society of Critical Care Medicine, created the Surviving Sepsis Campaign. So the goal of the Surviving Sepsis Campaign was to collaborate and formulate the best practice guidelines related to sepsis diagnosis and treatment. And their goal was to reduce mortality of sepsis by half. I don't remember the exact date when they said they were going to accomplish this, but I do know that they have significantly reduced mortality related to sepsis since they created the Surviving Sepsis Campaign in 2002. In 2008, NQF endorsed sepsis as a measure. And then you can see, and you probably recall that in 2015, Centers for Medicare and Medicaid Services adopted sepsis as a core measure, also called the SEP1 core measure. I'll use that interchangeably. And around that same time, 2014, 2015, were the infamous or famous trio of trials, if you will, that said we need to look at that early goal-directed therapy and really determine if that is the best way to treat the patients. So that was big as far as the evolution of sepsis. And then we'll talk a little more about 2016, 2018, and 2021. So I want to go back to 2015 just for a second. This is when CMS said that SEP1 was going to be a core measure. I'm not sure how it worked at your hospital in your area, but I know everyone here at Norton Healthcare got a little bit into a tizzy. We created a huge system team that said, we are going to solve the issue of this sepsis core measure, and we're going to make it incredible, and it's going to be amazing. And we're gonna, wipe our hands of it and say, great job, everybody. Now we fast forward to 2021 and we still haven't quite got it figured out, but we have made significant improvements along the way. But I think as a nation, we all recognized early on that this core measure is a beast. The core measures in themselves are proven to reduce complications and lead to better patient outcomes. The thing about the SEP1 core measure that makes it different from some of the other core measures, especially if you're familiar with stroke as an example, for stroke, you get credit for each composite piece related to that. So if you give the patient the aspirin within that certain amount of time, you get credit for that. But let's say that you miss the dysphagia screening. Well, you lose credit for that piece. With sepsis, it's an all or nothing measure. So we may do every single treatment component appropriately, but we fail to document in the correct order. And then it looks like we failed the entire case. With relation to this core measure, it's also been known to be the most time-intensive core measure related to data abstraction, which I thought was really interesting. I just learned that a few months ago at a symposium that I attended related to sepsis. So you can see this was documented in 2019. There are over 80 measures or metrics that need to be looked at related to one patient case. And then it can take anywhere from 30 to 90 minutes to score one patient case. Now, I know we have two very experienced data abstractors on our team who look at 104 charts every single month. And it easily takes them 30 minutes, sometimes longer, depending on what's going on with the patient. So this is a very time-consuming core measure. So I'm going to flip a little bit back and forth interchangeably, because I think it's important to talk about not only the core measure piece, like we just did, but I also want to make sure that we marry that or integrate that into clinical practice. That's, in my mind, and I'm sure in yours as well as bedside clinicians, that's the most important piece. How do we do this at the bedside? And inversely, how do we get the credit for the work that we're doing with the core measure? So when you look at the treatment for sepsis, the guidelines suggest certain things to be done within 3 hours and certain things to be done within 6 hours. I have those listed out here. You can see bolded, I have administer antibiotics and administer that 30 mils per kg fluid bolus. Arguably, these are the two most important pieces. Any patient that comes in with an infection, aside from sepsis, needs to have source control. And then, of course, they have to, if they're hypoperfused, we have to reperfuse them. So those are the two most important things. And when you look at this and you really think about it, you've got your patient that comes in, you suspect sepsis, or you know that your patient is septic, it sounds fairly easy. You get a lactate, you get your blood cultures, start your antibiotics. They're hypoperfused, you want to start your fluids. Their lactate's elevated, you want to trend that. So within 6 hours, you're going to repeat. Obviously, you're going to start vasopressors if their blood pressure is low and you've already given them fluids, and you're going to reevaluate them for that fluid status. Every time you're giving your patient fluids, you're going to continually monitor and assess them. So when you break it down and say it like that, it sounds fairly simple. The hardest part is actually being able to diagnose sepsis with relation to the core measure. And then, like I had mentioned earlier, actually being able to get the credit related to the work that you're doing with relation to that core measure piece. So let's look at those definitions for a second. This is based off of that 2012 update from Surviving Sepsis campaign. And when CMS introduced the SEP1 core measure, these are the definitions that they utilize. So think of this as kind of like a progression here. I'll go ahead and put them all up here. You have your systemic inflammatory response syndrome. So your patient comes in and they can have any two of the four abnormals: their temp, their heart rate, their respiratory rate, and their white count. If they have any two of those four that are abnormal, that's considered a positive SIRS response. If your patient has the presence of infection, either suspected or confirmed, and they have 2 out of 4 SIRS, that's the definition of sepsis. If your patient has sepsis plus 1 sign of organ dysfunction, that's the definition of severe sepsis. And then septic shock is going to be if your patient is not fluid responsive or their lactate is greater than or equal to 4, they fall into that bucket of septic shock. Now, this is especially important because in 2016, Surviving Sepsis Campaign updated their guidelines and they made a huge update to the definitions, which is really important because they decided that the definitions that were put forth in 2012 were a little confusing. And so they wanted to try and make it a little more clear, recognizing that we already have issues with being able to diagnose sepsis itself. And then again, whenever you're looking at the ICD codes and getting the credit and really understanding how many patients out there are septic, when we're looking at that literature and research, it was a little difficult to do that piece. So the definitions were updated in 2016, and you can see it here listed out: sepsis with circulatory and cellular metabolic abnormalities, profound enough to substantially increase mortality. So the issue here is that, again, the definition was updated by the Surviving Sepsis Campaign guidelines, which the guidelines are what we follow in clinical practice. However, Centers for Medicare and Medicaid Services said, that's great, but you're still held to the SEP1 definitions. We are still using the 2012 definitions. So a little bit of disconnect there with the guidelines and what we're held to as far as a standard for reimbursement and penalties, unfortunately. And then in 2018, Surviving Sepsis Campaign again came out with an update. Not a lot had changed other than the recognition that we really shouldn't focus so much on the 3-hour and 6-hour components. And they combined it all into the hour 1 bundle. And you can see here, it's essentially everything that was in the 3 and 6 hour, with the goal trying to get it done as soon as possible. So there was some significant pushback from various organizations related to the hour 1 bundle. And this one hasn't been as heavily as adopted. But really, when you break it down and you take away from this, it's essentially everything that you were doing in the 3 and 6 hour bundle, just with the goal of get it done as soon as possible for these patients. Getting that antibiotic on board sooner than later is vital. Reperfusion therapy is vital. So again, it wasn't as heavily accepted. And then drum roll, please, hot off the press, 2021 guidelines are now out. I just found out this morning that they were released last week. So I will tell you that I have been frantically going through those guidelines, looking for the most important nuggets of information. I will make sure that these slides get sent out to the appropriate parties so you guys can have these after our presentation today, and you'll have that link right there on the presentation so you can go and look at these guidelines in its fullest extent at your leisure. By way of quick glance, it doesn't look like a lot had changed, or what did change is not really surprising, in my opinion. One thing that kind of stood out to me was that they had added a statement about not using IV vitamin C, recognizing that a couple years ago that was pretty big in the literature. A few updates related to fluids, which we'll get into in a little bit, as well as antibiotic therapy with recommendations. So not a lot of changes, but it's, if you're interested, I don't want to say a nerd in the bad way. If you're a nerd like me in a good way, and you find these things interesting to read, please take the time to do so. It's pretty good. So back to sepsis itself at the bedside. As far as what that diagnostic criteria looks like, I mentioned that systemic inflammatory response syndrome, or SIRS, earlier. You can see that criteria listed out here: the temp, the heart rate, the respiratory rate, and the white count. If you have 2 out of the 4 that's abnormal, you got to have a source, either suspected or confirmed. Typically, you're going to see bacterial contribute the most to sepsis, and 1 sign of organ dysfunction. And the criteria are listed out there. So there's quite a few criteria to try and remember. Now, one that I think is interesting that's not listed out there is altered mental status. We know, or at least what we've seen here as well at Norton Healthcare with our OB population that unfortunately have become septic, we've noted that altered mental status can be one of the first signs that our patients are deteriorating in the OB population. So being mindful of that altered mental status, even though it's not listed here. The reason I mention that is because we need to, as you guys are aware, take our patients' entire clinical picture into consideration, not just looking at it in this silo related to sepsis as far as what's going on with them. And another thing that I want to point out here is relation to the SIRS criteria. Yes, okay. I did add this little bubble on here. This was another piece that had come out with the 2021 update, was that the Surviving Sepsis Campaign recommends against using QSOFA compared to the other screening tools as a single screening tool for sepsis or septic shock. So what they're saying is, again, like I just mentioned, we can't use this in just a silo. We can't look at just the SIRS criteria. We know SIRS criteria is a very sensitive indicator, but it's not specific to sepsis. Your patient can come in with AFib with RVR and they've got an elevated heart rate, probably an elevated respiratory rate. They've hit 2 out of the 4 SIRS. Are they septic? Maybe if they have an infection, but it might just be AFib with RVR exacerbation. So making sure that we take into consideration all the things that are going on with our patients. Don't just use the SIRS criteria in isolation. You can consider the NEWS screening tool, the MUSE screening tool. Consider QSOFA. That helps determine the level of how likely the patient is to decline and end up in the intensive care unit, but it's just stating not to use that in isolation. And I feel compelled to mention a little bit more about vital signs as far as not looking at those in just a silo. So I teach a monthly class for nurses here at Norton Healthcare, bedside sepsis class, and we talk a lot about vital signs. And the reason we talk about vital signs is because vitals are vital for a reason. We need to highlight the basics. I remember when I was in nursing school, that was like one of the first things that you learn about. You learn the normal versus abnormal measures. You know that it is very important as that student nurse, you go tell the nurse about the vital signs. You don't just look at one single vital sign by itself. You've got to look at the entire clinical picture, identify those trends, determine what's normal versus abnormal for your patients. But I think sometimes we get really relaxed with this. And admittedly, we've noticed this sometime in some of the cases that we've missed here at Norton Healthcare. When we go back and we look at the cases to review them, I will point out as an example of, well, their heart rate was in the 70s, and now all of a sudden it jumped up to 90, even as high as 100, which may be normal, may be explained by something else. But if we're not looking at those trends, miss a patient deteriorating. So you can see here the study was conducted in 2011. It looked at those vital signs and it found that if there was one abnormal vital sign, there was a 0.92% mortality, 3 abnormal vital signs, 23.6% mortality. Now, again, this is not isolated to just sepsis, but in my opinion, when I'm talking to the nurses, we talk a lot about this is just good critical thinking and clinical reasoning when you're out there on the floor, making sure that we're actually looking at those vital signs and truly assessing them. It can be easy to fall into that task-oriented mantra of, okay, I do my vitals at 8 o'clock and I do my vitals at 11 o'clock or noon, and so forth and so on. One more thing about vital signs that I thought was interesting, there was a study that looked at respiratory rate and counting respiratory rate. And so you can see it is a 2013 research study. It included 368 patients, and there was an observer that was assigned to each nurse. And the nurses were told that the observers were there for some other reason unrelated to counting respiratory rate, but the observers were really there to count the respiratory rate at the same time the nurse did. And what they found was that the nurses on average counted a respiratory rate of 16 when the observers counted an average of 18. And so the takeaway was that respiratory rate is poorly measured. Now I know I have minimal information on here related to that study, but I do have the citation for if you guys want to look at this later. I thought it was really interesting. And I do know that we have seen this in clinical practice. I was probably guilty of this as a nurse at the bedside, glancing in, counting for 15 seconds. Yep, that looks like 16 respers. But in all seriousness, I was reviewing a case not too long ago, and it was it was a perfect storm. Everything that could have went wrong for this patient went wrong for this poor patient and the poor nurse. It was a new nurse on night shift carrying a very heavy load. The particular patient in question had come in for an elective procedure, so you would assume that the patient was going to be doing okay. But the big thing that we had noted on that was the respers were 16 all night long, 16, 16, 16. Finally called a rapid response around 7 o'clock in the morning, and when the patient got to the ICU, the respers were 31. So I know within an hour the respirers did not go from 16 to 31. So again, I try to impress upon the nurses that respiratory rate is really important along with all the other vital signs. You can see here another study was conducted in 2017 that wanted to look at what were the top metrics associated with identifying an infection in patients. And number one was respiratory rate, followed by heart rate, age, systolic blood pressure, diastolic, and then the white count was actually ninth on that list whenever they plugged this into the machine learning multiple regression. So again, just really interesting, heavy emphasis on those vital signs. You don't need necessarily any fancy gizmos or gadgets or screening tools. You just got to take their vitals and you got to look at your patients. So from the beginning, related to sepsis, you got to have a source. The most common infection associated with it is going to be pneumonia, followed by UTI, wound, abdominal, and device related. And about 85 to 90% of our patients are starting in the community, meaning that they're developing these patients outside of our hospital walls, and they're showing up most likely in our emergency departments, or they might first stop at our primary care providers' offices. And then they just progress and deteriorate. So again, we're going to see the majority of them come in through our emergency department. Some patients will develop sepsis inpatient. Unfortunately, post-op sepsis is a thing. That is also something that we measure, and we are penalized or reimbursed on depending on how well we're doing. And then we can have our patients develop sepsis as a transfer direct admit. Now, what we do know is that if a patient develops sepsis inpatient or post-op, there's a higher mortality rate associated with that. Again, that's attributed to the fact that when they come in like through the emergency department, you've got a blank slate to start with as far as an investigation. You don't really know what's going on with your patient when they present to you in the ED, and you start thinking about all the differentials. If they develop it inpatient or post-op, you've already had a primary diagnosis, or usually you've already got a primary that you've been following. So it's easy to get that tunnel vision without taking that entire clinical picture into perspective sometimes. So opportunities related to misses at this point, all three of those kind of go hand in hand as far as existing workup, provider availability, and then handoff and communication. Just making sure that we are communicating appropriately what we think is going on with the patient, what we've already completed, making sure that there is a provider or nurse available. When I say provider, I mean the clinician who's going to be at the bedside, albeit nurse or provider. And then again, what has already been done for those patients? And I mention this because I think it's everywhere. We know that 80% of healthcare related failures occur because of a communication breakdown. And what we've seen a lot when we review our sepsis cases here at Norton Healthcare is that there was typically an element of handoff or communication, which also ties into that availability piece. It seems, it's almost like inevitable. The stars align, and it's always that case where the patient was a direct admit to a floor. The report was given to the day shift nurse, but night shift is the one that's there now because it was shift change and we magically had a bed open. So just being mindful of what's being communicated, and recognizing where your patients are in the context of that 3 and 6 hour bundle and getting those interventions completed. And I mentioned that because we did have a case where we had a rapid response at Norton Healthcare, and it was amazing. The provider was actually on the floor, ordered the sepsis workup, ordered a transfer for the patient to go to the intensive care unit, had put in, again, all the orders related to sepsis, and then the patient transferred to the ICU. The pharmacy received the orders, and at the time that the pharmacy received the orders, the patient was still slated as being in the med-surg unit. So the antibiotic was sent to the med-surg unit. Well, and of course it was shift change. So the day shift nurse in the ICU quickly got the patient settled. And by the time the night shift nurse recognized that the antibiotic hadn't been given, we were at least 6 or 7 hours delayed with getting source control for this particular patient. So starting with those bundle components, within 3 hours, you've got your patient that presents, you suspect that your patient may be septic, or you know that they're septic. We got to get that lactate. So this is typically elevated in patients with severe sepsis or septic shock. It's essential to identifying tissue hypoperfusion. It doesn't define sepsis, but it's one of the best labs that we have right now to help us identify those patients and how well they're doing. There's various reasons that your lactate can be elevated. So again, this is one thing, especially when I'm teaching my nurses, that I really try to impress upon them as well, to take the whole clinical picture into consideration. I've heard a few times when I've been rounding on the units, their lactate was normal, so the patient's not septic. We don't know what's going on. Well, we know that's not exactly true. Sometimes your patients aren't going to have an elevated lactate. Or there have been instances that have been really interesting where med-surg units have refused to accept patients to the floor from the emergency department because their lactates were elevated. It's like, well, yeah, their lactate's elevated because they have cancer and the cancer is elevating their lactate. It's not because they're septic. So just keeping that in mind as well. Blood cultures. So blood cultures is also within that 3-hour bundle. Our goal at Norton Healthcare is to get those within 45 minutes from time of presentation. And you can see there, only about 30 to 50% are positive in the context of severe sepsis or septic shock, but it does offer the best hope in identifying the causative organism. Now, common sense related to healthcare medical practice would tell you that if you think the source is somewhere else, go ahead and get a culture from that other source as well. If they have that oozing wound on their backside, you probably want to culture that too, just in case. Ideally, you want to get the blood cultures before you give the antibiotics, but we definitely don't want to delay source control. And then from that core measure perspective, blood cultures are considered, quote, good for 24 hours prior to that time of sepsis identification. So if you had that patient that went into the clinic, they went to a wound clinic, they drew blood cultures for whatever reason, and then 18 hours later, the patient presents to the emergency department and you've got record of those blood cultures, you don't have to repeat those with relation to the sepsis core measure. Now, I know typically best practice is going to say that you probably need to collect those again because your patient has left a clinic and now they're returning, but just wanted to comment by way of that core measure. Also within the 3-hour bundle is antibiotic therapy. So our goal is 1 hour from presentation time or from that time of identification. Now, one study that's worth mentioning was conducted in 2006. It was done by Kumar and colleagues, and they set out to look at antimicrobial therapy and time to initiation in patients with septic shock specifically. So you can see there they had a pretty large population of patients, a little over 2,500. And essentially what they had found was that every hour delay in antibiotic therapy, survival decreased by 7.6%. Now, I do want to point out that this does say that they studied patients with septic shock. So again, it's really important to look at these studies in the context that they were. Words, definitions are important. So that's the population that they looked at. I mentioned that because in the updated guidelines, there's a few nuances related to if you think the patient is septic versus if you think the patient is septic shock with when or how quickly you start antimicrobial therapy. But again, that would be another topic for another day. We're not going to focus so much on that piece. Opportunities related to misses with antibiotics, timing. So we have had, unfortunately, here I can speak to Norton Healthcare again, some instances where we've delayed antibiotics because we were unsure if the patient actually had an infection. So if we suspect that the patient might have an infection, the idea is to err on the side of caution and go ahead and give a dose, a one-time dose, if anything, of broad spectrum antibiotic therapy. Another issue that we've seen related to this is the communication with timing. So we do a really good job when the patient comes into the emergency department, all hands on deck, you've got your nurse there and your provider there. You get the patient settled, maybe the provider goes and puts in orders, and maybe the nurse hasn't been in the chart for a couple hours. And next thing you know, that antibiotic that that provider ordered was still sitting there because the nurse hadn't seen that it had been ordered. So just making sure, especially for these patients that come in with suspected infection or sepsis, making sure that we get those antibiotics started on time. Perfect. Hopping into that 6-hour bundle, lactate, this seems pretty straightforward and easy to talk about. If your initial lactate is greater than 2, you have to repeat that lactate related to that core measure. So there was a study conducted in 2009 that I thought was really interesting. It found that if you had lactate clearance, which was defined as 10% decrease in about 2 hours, patients had a 19% mortality rate when compared to patients who had their lactate drawn at the same time and it was shown an increase. they had about a 60% mortality rate. So when I talk to my providers and nurses about the lactate, it's easy for us here at Norton Healthcare, for whatever reason, we've started getting a little relaxed with the repeat lactate, and we've missed it a lot related to the core measure, unfortunately. And we get relaxed by way of saying, well, their lactate was only a little elevated, so, nobody called me about it, or I didn't think to follow up on it. We do a really good job when our patients come in and they're really sick. We can take care of those. We identify that quickly. It's those in between that 2 to 4 range that sometimes we have issue with. But if your lactate is greater than 2, you have to get a repeat. We do this because we want to look for those lactate trends. If it's increasing, we need to start asking the question, do we have the appropriate source? Is there another location that maybe we haven't identified? Are there any other additional issues that are going on? Have we applied the appropriate interventions? Did we give a fluid bolus? Did we give fluids at all? Do we need to give more fluids? So things to consider with the lactate. The infamous crystalloid or fluid bolus, 30 mils per kg fluid bolus. This needs to be started or initiated within 3 hours from that criteria being met. The true definition of bolus is 500 mLs in 15 to 30 minutes. So when your patients are truly hypoperfused, we need to be getting a pressure bag, and we need to be getting these fluids in them as soon as possible. You can see there, and you guys are very familiar. Obviously, it's given to expand the circulating volume, restore perfusion pressure. Even if the patients are not hypotensive, the research has shown that there's poor outcomes correlated with that lactate that's greater than or equal to 4. So making sure we identify that as well, and making sure our nurses are knowledgeable to recognize that you might have a normal blood pressure, but if your lactate's elevated and it's a critical lactate, these patients meet that requirement for that fluid bolus as well. Now, I did want to comment a little bit more on this fluid bolus piece with relation to the core measure for those that are interested in that piece. As far as the criteria, so like I said, this has to be initiated within 3 hours of time of criteria being met. It does not have to be slammed in or given within that 15 to 30 minutes for every single patient. Especially we know that some of our patients that have the renal disease and heart failure may not be able to handle the bolus per the definition like that. So being mindful of that. Also, ideal body weight versus actual body weight dosing. I will comment a little bit. I do dabble in the pediatrics because I sit on their committee. We have a really good, robust program at Norton Children's Hospital. And so all of their doses are on that ideal body weight. So I thought that was really interesting when compared to, because when the core measure came out, ideal body weight wasn't even an option to dose the fluid bolus for the adults. But anyway, you can dose it on the ideal body weight now if your patient has a BMI greater than 30. So this is also really helpful for our morbidly obese population and also our pregnant population, because again, we do see some of them coming in with sepsis and they are treated for that, but we would like to use their ideal body weight, not their actual body weight. Documentation, I'll show you a little bit of that here in a second. And then we've seen here at Norton Healthcare related to misses with the fluid bolus. Obviously timing's always going to be a potential opportunity if we don't get it started within the time frame. Not giving it, not enough. We know that it needs to be 30 mils per kg. And then what we seem to have the biggest issue with here at Norton Healthcare is bolus documentation. Now, I did want to comment because I thought this was interesting, which we have seen a lot in the research over the last few years. The 2021 guidelines did update their recommendation. Historically, it had said that they suggested using either balanced crystalloids or saline. They've updated their recommendation to say they suggest balanced crystalloids instead of saline for resuscitation, which we've seen that again in the literature over the last few years to be balanced crystalloids superior to the normal saline boluses. So as far as that documentation piece that I wanted to mention, with relation to your patient and the decision maker for the patient can always refuse that bolus. we've had some instances here at Norton Healthcare where it just was not appropriate to give the fluid bolus based on the clinical picture of the patient and based on clinical judgment of our providers. And I've heard that in many of the presentations that I've sat in, and many of the subject matter experts that I've talked to as well. The intent of the guidelines, you almost need to consider them with an 80-20 lens, that the intent is for your general population. There will be some patients that are just not going to fit that general guideline. Some of those patients will be related to this 30 mils per kg fluid bolus. Their bodies just aren't going to be able to handle that much that quickly. The other two pieces of documentation that a provider can put in the chart with relation to giving a smaller amount of bolus is that your patient has advanced or end-stage heart failure or advanced or end-stage chronic renal disease. And then another thing that I like to point out for our nurses, especially to document, is that prior to admission, fluids or antibiotics, anything that's done before the patient gets here, because I know EMS is really good about getting treatment started. If there's documentation in the chart that shows that fluids were administered, that can be included as well. So that can help take off some of that burden when the patient gets here by saying, you know, they've already been given a liter en route, so we're only going to give them what's after the 30 mils per kg versus giving them an additional 30 mils per kg. And vasopressors, these are pretty straightforward with relation to the sepsis core measure. And this is essentially rounding out that 6-hour piece of the bundle. So you apply vasopressors if hypotensive during or after fluid resuscitation to maintain that mean arterial pressure of greater than or equal to 65, nor epi is the recommended. One thing that was also added to the 2021 sepsis updates, which I thought was really nice, is that for those patients with septic shock, they suggest starting vasopressors peripherally to restore mean arterial pressure rather than delaying initiation until a central line is placed. So there have been a few research studies out there related to giving vasopressors peripherally versus centrally, and studying whether or not the patients had anything happen related to that, any bad side effects. And so there essentially haven't been too many reported that were statistically significant to suggest that you should delay therapy if you don't have a central line. So it's okay to go ahead and start those in a peripheral if that's all you got. So kind of switching gears now, we've talked about the core measure. We've talked about walking through that 3 and 6 hour bundle component all the way from identification through treatment in that acute phase. Who are our high-risk patients? What populations do we really need to be focused on? There's quite a few of them. So if you are in primary care, you might even be thinking, well, shoot, this is like 90% of the patients that I see. Yeah, because sepsis doesn't really care who you are. It can impact anyone. You can see there my last bullet, which I, again, try to impress and emphasize, especially with my nurses when I teach their class, that any infection can lead to sepsis. So we need to be mindful of this every time that we have those patients in our hospital. But watch out, be on the lookout for patients that are 65 or older, children younger than 1, weakened immune systems, chronic medical conditions, sepsis survivors. I thought this was really interesting. And this statistic was, I had put this out there because it's been in the literature, but it was also quoted by the it was quoted within the rationale related to the 2021 updates as well. 40% of patients are readmitted with infection or a comorbid exacerbation within 3 months after their initial sepsis incident. So they come into the hospital, they were maybe even otherwise healthy, and they come in because they become septic, and they leave our hospital, and then they're readmitted. That's a pretty staggering number. We may say, well, it's less than half, but if that were my patient, if that were my loved one, that can be pretty disturbing to see. And then considering our non-vaccinated individuals, making sure that we don't lose sight of those vaccinations. Those are really important. Recognizing that pneumonia is the #1 infection that causes sepsis, and we have a pneumonia vaccine. We need to be thinking about that for our patients to help prevent or reduce their risk of developing sepsis or an infection in general. Long-term effects. So this gets into that post-sepsis syndrome that I had mentioned earlier in the presentation. 40 to 50% of sepsis survivors experience post-sepsis syndrome. I think that is huge when you think about all the patients that you've had that may have experienced sepsis. My mom personally is one of them, and she has some long-term lasting effects related to her experience with that. You can see here that the symptoms can include anything from challenges with cognitive function, anxiety, concentration difficulties, insomnia, difficulty sleeping, muscle and joint pain. There's also a high prevalence of mental health problems related to post-sepsis syndrome. You can see there one study that was reported in JAMA in 2018 showed 32% of patients had anxiety, 29% had depression, and then post-traumatic stress disorder was also pretty high on that list. Now, there's another study that's not on here, but again, I thought it was really interesting. A group of researchers did an observational study where they looked at over 30,000 sepsis survivors, and they found that the patients that had referrals to a rehabilitation clinic or clinics within 90 days had a lower risk of 10-year mortality. So my takeaway from that in relation to what we're seeing here as far as those long-term effects are how important it is for these patients to get in for their follow-up with their primary care provider. They at least need to have that scheduled, or at minimum have it planned to be scheduled before they leave our hospitals. It's really important. It will help reduce the risk of their further medical setbacks. And again, hopefully that goal is either setting up rehab or support programs as necessary if that hasn't already been done before they leave our walls. Can we prevent post-sepsis syndrome? Well, that's the interesting thing, the frustrating thing as well, in my opinion, because prevention needs to start before we even identify that there's a problem. So there's no screening or assessment tools that exist to determine who might develop post-sepsis syndrome. We can assume they're going to be patients that are typically older or typically have more morbidities related to this already, such as developmental issues, etc. But it's not always the case. It could be the otherwise healthy patient that had come in and developed sepsis and now has been in the ICU. So strategies to mitigate this or reduce the effects include that A, B, C, D, E, F bundle. No, I'm not going to say the whole alphabet for you, but we're pretty darn close at this point. But you can see there, that's pretty important to helping our patients and make sure that they have the best success to get out of our hospitals. You want to make sure that we're assessing pain, doing the breathing trials on our patients if they're intubated, choosing the appropriate minimal analgesia and sedation. So also doing those sedation vacations, monitoring for delirium, early mobility, even if they're on the ventilator, and then making sure that we engage the family and empower the family. Family is going to be huge because we as in the bedside clinicians, we can be an amazing support system while the patients are here. When they leave, they might have no one outside of our hospital. So making sure that we do get that family engaged and empowered to help go home with the right social support. Making sure we're using those handoff tools for care continuity, minimal use of invasive lines and restraints, and then bundling care interventions to allow for rest. So these seem pretty commonplace as far as, Danette, we should be doing this all the time. But we also know, again, that we can get pretty relaxed or pretty tuned into our task-oriented work as far as we got to do this, we got to do this, we got to do this. And sometimes we can lose sight of the big picture as far as bundling our care to allow our patients to rest. Handoff tools for continuity. Care continuity is huge. It's even as simple as knowing what to call your patient, looking at that ABCDEF bundle, reducing delirium or monitoring for delirium. I had one patient one time when I worked in a neurosurgical ICU. I won't forget this because it really just threw me off. I would always ask what my patients preferred to be called. And I think this patient's name was William. So I had in my head, I was expecting him to say Bill, call me Bill. But he said something like, call me Scott. So it really threw me off because I was not expecting that. But again, I think it shows the importance of really getting to know your patient because that could help with that delirium piece, help keep them oriented to who they are, where they are. This is your family. Today is Tuesday, October 19th. It is afternoon now. Making sure that we're having those conversations because they are really important for these patients. And what we're doing then is we're setting them up for success to get out of our hospitals, hopefully with less side effects and less post-sepsis syndrome issues. Another emphasis on that cognitive and psychosocial impact. So the downside to all of this, as I just said, we need to start preparing while they're still in-house, but we can't always discern this piece in the acute care phase. So relying heavily on family and friends is really important from that clinician perspective, and making sure that we assess their cognitive status in the primary care setting. Because when you think about it again, I had mentioned that clinicians, us at the bedside, we can be a great support system for our patients. I mean, I loved helping my patients get set up for meals. Here, let me help bathe you. Here, let me make sure I've got all the things here and I take care of you. That's our job, right? We're in healthcare because we want to take care of people. And then they go home and they don't have us there. So it can be hard to assess their cognitive status when they're in-house, because a lot of times clinicians are doing a lot of the work for them. So being mindful of that and making sure that we assess for that once they leave our walls. And then taking into consideration with that psychosocial impact, the family dynamics. These patients, you may have a patient that was the sole caregiver for, and now that they've had sepsis, they've been in our hospital for 20 days. They're going to rehab, they're going to an inpatient facility afterwards. Who's supporting their family? That's not to say that we're going to support their family, but we need to be considering for them, what do those community resources look like, and getting them again set up for success to make sure they don't come back, or they can thrive outside of our hospital. Emphasis on that physical impact. Consider if your patients were intubated. We know that this can weaken their muscles. They may have difficulty swallowing and difficulty talking, and preparing the families for that as well. I know that was one thing, again, when I worked ICU, it could be a surprise or a shock to the family members to hear how hoarse their loved one sounded, or the fact that they couldn't talk to them right now. And, they would fuss about it quite a bit. So just preparing them, like, their muscles are weak. We got to get that built up. And just in general, that musculoskeletal impairment after having laid in bed for however long they have, without their muscles being utilized. We need to, again, implement that early mobility as soon as possible. And we know that early mobility does mean, yes, getting them out of bed if possible, but it also could mean the passive range of motion. It's those simplest things that are foundational to ensuring our patients are set up for success. And then another disheartening statistic, many of our patients are going to fail to reach the functional independence level. 17% have severe persistent impairments. So you can see there as an example, inability to bathe or just dress themselves. Again, going back to my personal story about my mom, I can remember how devastating that was to her to be able to go home. And it was around Christmas time, and God love her, she just wanted to wrap the Christmas presents for the kids, and she couldn't do it because she just didn't have the energy and the muscle capacity to do so. Which was really hard to watch as someone in healthcare as well, and being her daughter. And so just making sure that we set people up for that, to prepare them of some of the things that they may see when they leave the hospitals. I'm going to touch on community resources. So specifically here in Kentucky, we have the Kentucky Sepsis Consortium. It's through the Kentucky Hospital Association. I do believe Deb Campbell is still the lead of that. So work with your hospital leadership to see if there are any resources that you all can pull from the Sepsis Consortium. I do know on their steering committee, they have community patients, people who have had sepsis, so sepsis survivors who have amazing stories and who are more than willing to come into the hospitals, talk to patients, talk to the healthcare teams to give them kind of that firsthand what it looks like. Sepsis.org is another really good website to utilize as a resource, even for patients and for providers. The Sepsis Alliance was started by Dr. Carl Flatley, whose daughter was in graduate school and had come home on break for an elective procedure. And I remember listening to a video recording of him, and his quote was that she was having issues that were just kind of passed off on a Wednesday, and she was dead by Sunday. And so he started looking into what happened. How did this get missed? What is this sepsis that they taught? And I think this was back in 2006. And at the time, there weren't a lot of community resources out there. So Dr. Carl Flatley founded the Sepsis Alliance, which his goal was to help educate the community about what sepsis is and ideally prevent it from happening. NAMIKY.org. So I'm not sure if you all are familiar with that. That's the National Alliance for Mental Illness. They do have a Kentucky chapter. So again, trying to think of that holistic patient picture. Now, I'm not sure if there are any local to Carroll County or where those are located, but that could be something to offer patients as way of community support. Obviously, PT, OT, speech therapy, post-critical care clinics. Put an asterisk beside that because that is not something that we have access to all over the country, but some places have started developing clinics that are specific to either post-critical care or post-sepsis, with the emphasis on that holistic view of the patient and trying to get them back to a functional status of independence. And then I just challenge, what else? Be thinking in your heads, in your practices, what else do you guys have to offer that's within your local region for our patients and their families? Ultimately, prevention is going to be the key, because we know, again, that any infection can lead to sepsis. If you don't have an infection, you don't have a location for that infection to get inside your body, you don't have a way for it to get there, you're not going to become septic. So be thinking of hygiene practices. Think about what your patients need to know about this when they come to primary care. Do we talk about making sure that they're preparing their food well? Just as simple as hand washing, the water quality. I mentioned those things, especially again, from personal experience, having lived on a farm. My dad has cattle, he has chickens, and we talk a lot about the hygiene practices, especially when we talk about the chickens, and he's meticulous when caring for his chickens and his eggs that he collects. But anyway, I digress. Access to vaccinations. We talked about the pneumonia vaccine earlier. This is huge as well, making sure that our patients understand the importance of helping prevent the infections by way of getting a vaccination, and appropriate nutrition, taking care of themselves. Antibiotic stewardship's another big one. I'm actually working on a project right now that's looking, again, it's in pediatrics, not the adults, but it's looking at pediatric ceftonir. And the project's recognizing, the project is related to the fact that about 20% of the time, we're still ordering ceftonir as a first-line choice for a lot of infections when we know that it is not supported in the literature to be a first-line medication. So working towards antibiotic stewardship and making sure we've got the right drug for the right bug, if you will. Prompt seeking of medical attention, early detection, empowering our patients all kind of go together, especially empowering our patients to see, if they see something, say something. If they think something's wrong, they need to say something, and they need about it. No, that doesn't mean go to Dr. Google and find out what Google says about it, but that does mean to go to your provider and say, hey, you know what, I heard about this, or I'm feeling this, and being able to have that open conversation to empower our patients, because they know their bodies best. They may not always be able to say it in the words that make sense, but they know how it feels. So it's on us as the healthcare providers to make sure we're asking the appropriate questions and saying the appropriate things to our patients, so we've empowered them to take care of themselves. And I'll leave you with a couple more things. Number one's a call to action. Be thinking about what your response is to suspected sepsis. What is it now? Is it going to change after hearing some of the things that you've heard? What do your patients know about the risk of sepsis? Is there something else that you need to do to make sure that they're familiar with the risk? What resources do they have? If you were a patient and you were septic and you came to the hospital, what would you want from the protocol? And in my mind, what more importantly, most importantly, I don't know, it's all important, but how do we make sure you get home and you're successful at home outside of our walls without us? And finally, in summary, just a few takeaways. Defining sepsis is more difficult than actually treating it. There are treatment protocols supported by Surviving Sepsis Campaign guidelines, and they're available for clinical practice. And again, that update just came out, so I'll make sure you guys get that link. You can go look for it. Preventing infection is vital to stopping sepsis, period. Long-term management for sepsis survivors is absolutely necessary and is something that we really need to be focusing on in clinical practice. And how do we get these patients outside of our hospitals so they can take care of themselves and continue to live their lives? And I don't know if we have time for questions or not. If we do, I'm happy to take them. If we don't, you guys have my email now. Again, I'll make sure to send these slides out. You'll have my cell number. So if you do have questions, please let me know. I have a list of references to end with. And thank you very much for your time and for listening to me talk about sepsis.
Thank you so much. I appreciate all your help.
You're welcome.
All right, I'll let you know if they have any questions. I'll send them your way. Thanks so much.
Appreciate it.